Okay, Spirochetes, lecture 13. Okay, so basically terminal objectives, I'm gonna talk about identifying clinical significance of the various spirochetes. There aren't that many. We're gonna get into the treponemes. Here's taxonomy. Treponemes, there are 4 major treponeme species and subspecies that I want you to know. After the treponemes, I'm going to talk about Borrelia, and there are 2 specific species of Borrelia that you need to know. And finally, in this lecture, the last one will be Leptospira, which is one organism, and then I'll talk about those, basically how to identify them, the Leptospira based on when you collect the specimen. So the first one will be treponemes. So here in the taxonomy, well, let me go. And Borrelia, the 2 species of Borrelia, and Leptospira interrogans. Okay, treponemes. These are helical rods, motile, tight regular coils. They look like springs, like the spring in a pen. They're very small, microaerophilic. They require oxygen, but not that much oxygen. You don't typically do a gram stain on these. They stain very, very poorly. So the way to identify these organisms is either by serology or by direct fluorescence antibody or Darkfield Microscopy. Okay, so these treponemes are best observed with Darkfield or phase contrast microscopy. And I'm going to go over how Darkfield Microscopy works in the middle of this lecture. Some human pathogens are cultured, some have never been cultured. Basically, a lot of these treponemes are found in either the oral cavity in your mouth, that's why you need to brush your teeth, the intestinal tract and genital areas in man and animals. They're very easy to treat. They're extremely susceptible to heat, cold, desiccation, soap, osmotic changes, and disinfectants. So they're very easy to keep, but when they start get going, they can cause problems. Okay. So these are the 4 main pathogens of the treponeme species. Treponema pallidum, Treponema subspecies pallidum, subspecies pertinu, Treponema keratinum, and Treponema pallidum subspecies endemicum. Now, in the handout that I gave you, the order is a little bit different. And the reason why I changed the order is because I want you to memorize it the way that I learned treponemes when I was in college. Okay, so the diseases, and I'll mention this to you later on in the lecture, the diseases that these treponemes cause. Pallidum is easy. Pallidum causes syphilis, okay? Treponema pallidum causes syphilis. And then the next 3 is, if you notice, it's pertinu, keratinum, and endemicum, PCE, okay, PCE. And that corresponds to the diseases Yaz, Pinta, and Bagel. Now, when I learned the treponemes in college, my professor says Yaz, Pinta, and Bagel consistently. He always said Yaz, treponemes are caused by cause the diseases Yaz, Pinta, and Bagel. So pertinu causes Yaz, keratinum causes Pinta, and endemicum causes Bagel. Okay, you'll see the spellings later. But if you organize this in PCE and memorize the organisms as the diseases as Yaz, Pinta, and Bagel, then you'll do fine. Pallidum is easy. That's one. It's the only one that repeats itself. And 2, it's syphilis. That's the most common disease of the treponemes. Okay, so pallidum is syphilis. Pertinu, keratinum, and endemicum corresponds to the diseases Yaz, Pinta, and Bagel. There are other species of treponemes like Vincenti, Pectinovorum, Sokransky, Refringens, and Denticola. These are commensals. They're they're kind of like normal flora, but they're treponeme still, okay? And they can be opportunistic. So they can be in those locations like the mouth, the GI tract, and also to the genitals of men. All right, but these are the non-significant species of treponemes. Pathogenesis. Okay, pallidum, Treponema pallidum. That's the one that causes syphilis. It's highly invasive. So once you make skin contact, it's going to penetrate the skin. Okay, venereal contact, predominantly in adults. You can get the disease congenitally and pass it on from mother to newborn or the embryo, and cause congenital infections. And all tissues may be affected. So congenital syphilis, if the mother passes it on to the newborn infant or the unborn infant, it may result in termination of fetal development. It is going to affect the baby. And it also may result in premature birth, and also too, it may result in fetal death. Incubation period for Treponema pallidum is 3 days to 3 months, with an average of 21 days, 3 days to 3 months for the incubation period. And the disease stages, there are 3. Actually, there are 4. These are the disease stages, but the 4th one includes a non-disease stage, and that's a latent stage. So there's primary syphilis, there's secondary syphilis. After the secondary syphilis, there's a latent stage, which the disease becomes subclinical. Okay, you think that you've gotten rid of it, or you think you're cured, but no, you haven't. And then it comes back into the tertiary syphilis. So there's 3 diseases, but there's a 4th stage, okay? So primary syphilis develops at the inoculation site. Remember, these organisms are invasive by skin contact, and it can penetrate the skin. And primary syphilis only stays for 3 to 6 weeks, about a month and a half. Secondary, this is primary syphilis, how it affects the genitals and the lip. Secondary syphilis, after the chancre, those are called chancre sores previously. After that, a rash develops, and now you're in secondary syphilis. And here a rash develops, and you get it in 2 to 24 weeks, okay, 2 to 6 weeks after the chancre sore, okay. During the syphilis, the secondary syphilis stage, that's where the organism is the most numerous at this time, okay. So the organism multiplied, and during the secondary syphilis stage, that's where the organism is the most numerous, okay. And it's a rash after the chancre sore. And there's a picture of a rash. Okay, so here's that latent period. So after the secondary stage, there's a latent period, and the organism becomes subclinical. That means it appears that all these rashes and chancre sores go away, and you feel that you're cured, okay? But you haven't been cured. You can still detect the organism serologically, but clinically, the sores have gone away. It looks like they're healed, but serologically, the organism's still present. And then finally, the tertiary syphilis will show up in 10 to 25 years. So that's quite a while. That's a long time, well after the secondary, after those 6 months of chancre and rash. After those 6 months, then it'll take 10 to 25 years before anything shows up again. So you think you're in the clear, but serologically, you're still positive. So here in the tertiary syphilis, you have CNS involvement, the central nervous system, cardiovascular abnormalities, you have eye diseases, and you have what's called gumas that develop. And what gumas are soft, non-cancerous growths. It's a form of granuloma, and it's commonly found in the liver, but they're also found outside the body as well, these gumas, okay? And so here are pictures of gumas of patients who are infected. Talking about the specific treponemes, I need to rearrange the slides. So I'm starting off with endemicum, Treponema pallidum endemicum. Okay, but remember PCE. Treponema endemicum causes Buergel. Okay, when I ask for what the etiological agent is, I'm asking for an organism. Okay, so if I ask for what is the etiological agent that causes erysipelas or pharyngitis, your answer would be group A strep, for example. If I ask for what is the etiological agent that causes the disease Buergel, the etiologic agent would be Treponema pallidum endemicum. Okay, so just wanted to make sure there's a little confusion on the homework as to what I meant when I asked for what the etiologic agent is. Okay. So endemicum is found in North Africa, Middle East, and Southeast Asia. So a little bit around the equator. And a lot of these treponeme infections, like for example, Buergel, affect mainly children. It's common in children in rural areas with poor hygiene, okay? Transmitted by mucosal lesions, spread by mucous membrane contact, eating and drinking utensils, and again, it affects mostly children. That's endemicum. The next one is Treponema pallidum pertinu, okay? So this is yaws. So the etiologic agent that causes yaws is Treponema pallidum pertinu. It's non-venereal, so you don't have it, so it's not by contact. Eruptions of tubercles, okay? And what tubercles are skin papules, nodules, and ulcers. And here it's found in Africa, South and Central America, and the Pacific Islands. Still kind of hovering around the equator, warm tropical areas. And again, it's in children. So this is Treponema pallidum pertinu. Those are the tubercles all over this child's body. So it's spread by skin lesions, again, primarily in children. And if untreated, may infect more skin, bones, and soft tissue. So it can be invasive. So it starts off in the skin, but then it'll penetrate down into the bones and the soft tissue. So this is Treponema pallidum pertinu. And there's some pictures of how the organism infects. Tertiary involvement, gumas. So there's more pictures of gumas. Okay, and the final treponema is Caratium. PCE, Yaz Pinta Buergel. So this is the middle one. So this Caratium causes Pinta. The etiologic agent of Pinta is Treponema Caratium. Remember, if I ask for etiologic agent, I'm asking for the name of the organism. Superficial invasive infection of the tropics, Central and South America. So it's around the same latitude. Spread by skin contact. It's no longer long-term systemic health effects. So you get it, but it's not really life-threatening. Affects all ages, but mostly children and adolescents. Okay, so basically, it's safe to say it'll affect children. Pinta can be found in adolescent, older children. And this is Pinta. All right. The non-pathogenic treponemes, like I mentioned, Treponema vincenti, denticola, sopransky, pectinovorum, and refringens. These are non-pathogenic. They're kind of like normal flora, but you don't want them to be opportunistic. If you don't have good oral hygiene, you don't take care of your mouth, for example, it's it can be opportunistic and cause problems. Species in the human genital tract, that's Treponema refringens. Again, this is a non-pathogenic treponeme. Can be cultured or cultivated anaerobically on artificial media, and may also cause ANUG, A-N-U-G, or Vincent's gingivitis. Okay, again, it's an oral disease. ANUG stands for acute necrotizing ulcerative gingivitis. So can do some damage inside in your mouth. Okay. Now getting into dark field microscopy. Dark field microscopy, in dark field microscopy, what you're looking at is the object in, the object is white against a dark or black background. And the key is to fine tune the numerical aperture between the dark field condenser and the ocular objective. So in dark field microscopy, remember, it's a white object. It's how the light is brought in, and I'll describe that later. It's how the light is brought in on the object, and usually it's oblique light. Oblique light is light coming in at an angle, as opposed to direct light coming up from the bottom, which is how you are looking at on your current microscopes. So dark field microscopy uses oblique light, and it illuminates the object. It's white against a black or dark background. Okay, so on the microscope, you have the objective, which is this thing here. This is the objective. The objective collects scattered light and generates a bright image of the transparent specimen. So that's why it's good to use dark field microscopy, because the specimen that you're looking at, the object that you're looking at, is transparent, okay, and it takes scattered light. The advantage of dark field microscopy, again, is that you have a black background, and it gives you high sensitivity, and it provides high contrast, which enables you to see the organisms. So, and the way you achieve that contrast, the objective of getting adjusting the dark field condenser and the objective lens is to minimize glare and to get really good resolution. So the way you do that is, if you have, this is the dark field condenser. If and what you're doing is you're adjusting the numerical aperture. So these two objects have numerical aperture values, okay? They have numerical aperture values. So if the numerical aperture of the dark field condenser is greater than the numerical aperture of the objective lens, then you will achieve no glare, and you'll get your dark background. That's what you want, okay? And then when you fine tune it, then you can also get good contrast. Okay, so this is what you want. This is optimal. This is an optimal condition where the numerical aperture of the dark field condenser is greater than the numerical aperture of the objective lens. The result is no glare and a dark background. On the other hand, if you have the numerical aperture value is less of the dark field condenser is less than the objective lens, then what you'll see in the microscope is you'll see a lot of glare. Okay, when you have a lot of glare, you can't see the object. It's like it's overly bright. Okay, and you don't want that. It's just like, I don't know if well, I didn't teach you a urinalysis laboratory, and you guys didn't do wet microscopy in so much in hematology. If I did, then I would have reminded you that if you were going to look at anything that is liquid underneath the microscope, the way that, if you want to see it clearly, is that you drop the condenser. You drop the condenser. Okay, if you do that, because if you have the condenser all the way up, then it's going to be, the object will be difficult to see. Like, for example, casts or bacteria or epithelial cells. But I know we're not going to have that opportunity here in microbiology, but if you drop the condenser when you're looking at something that's liquid or wet, you always, as a rule of thumb, if it's liquid, you drop the condenser, and then you'll see good contrast of the objects that you're trying to see, like epithelial cells. You can actually see casts better, or bacteria better. You should see the epithelial cells, but dropping that condenser really helps you see things like casts. So it's the same thing here. If you adjust the numerical aperture of the objective lens and the dark field condenser, you want to minimize the glare. So reducing the numerical aperture of the objective lens. So right here, this is a glare situation. Okay, this is a glare situation. The numerical aperture of the objective lens is too high. It's greater than the dark field condenser. So you need to reduce this, okay? Once you do that, then dark field can be restored. This has the numerical aperture of the objective lens has to be lower than the dark field condenser. All right, are there any questions at this point? Yes, no?
No.
Okay. I talked about light coming in, how light comes in. So there's this device called a dark field stop. Okay, so the dark field stop blocks direct light from entering the objective lens. Direct light, so it's direct light is like vertical light entering into the object, right? We don't want that. It's also gonna add to the glare. So what the dark field stop, it blocks direct light from coming in. And what we want is only oblique light, which is light coming in from an angle. And this light is refracted by the sample. And when that happens, the objects will become illuminated, okay, with the background still being light. So it's light coming in at an angle, which is oblique lighting. We want oblique lighting, we don't want direct lighting, okay? So we want light coming in from the side rather than having direct vertical light. So the dark field stop will prevent direct lighting from coming into the object. All right, so that's what the dark field stop will do. All right, any questions on that? Okay, I'm glad you got that. I hope you got that. So this is dark field microscopy. The object is white against a dark or black background. Okay, this is optimal condition. Okay, characteristics of treponemes. Okay, like I said, these are delicate corkscrew in shape, 6 to 14 micrometers. I'm not going to ask you these questions, but just know that the shape is corkscrew. These are not like your typical gram-negative rods, gram-positive rods with polar flagella, etc. These are corkscrew shape, and you're not going to be looking at these organisms on the gram stain because they don't gram stain very well. Okay. They are modal, slow, deliberate back and forth movement. Okay, screening tests for the treponemes. So usually when there's a screening test, the objective is to find out if the patient is positive for syphilis. Okay, so the organism is Treponema pallidum. Okay. Screening tests can either be Wassermann reagenic antibodies. No, we're not going to use that. Or reagenic IgE. No, we're not going to use that. But the two screening tests for syphilis that you'll be asked on a quiz, and these are screening tests, are the VDRL, the venereal disease, which stands for Venereal Disease Research Laboratory, or the RPR, the rapid plasma reagent. Keep in mind, these are only screening tests, okay? This will not say if you're positive, it will not tell you you have syphilis, okay? It's screening. So if you're positive, that means you have to do confirmatory tests. And the two confirmatory tests, antibody specific for treponema, are two of them, the fluorescent treponemal antibody, FTA-ABS. The FTA-ABS is the fluorescent treponemal antibody test. And the other one is the MHATP, which stands for microhemagglutination treponema pallidum. These two, if they're positive, either of them are positive, then it confirms that the patient has syphilis. Okay, it's specific for the Treponema pallidum organism. So two screening tests are the VDRL, RPR, and confirmatory tests are the FTA-ABS and the MHATP. Those will be asked on my exam, and probably if you get it in on your board exam, but make sure you know that the screening test versus the confirmatory test. Okay, that's it for the treponemes. Okay, are there any questions on the treponemes? If not, we'll move on to Borrelia. Two organisms in Borrelia. The first one is Borrelia recurrentis, which causes relapsing fever. So here's a trick: recurrentis, relapsing, recurring, relapsing. Okay, so relapsing and recurring, recurrentis, they go together. Okay, and make sure you know the vector is lice, and you'll need to know the Latin name for it. But recurrentis will cause relapsing fever. The other one you kind of know about is, but not the name of the Borrelia species, is Borrelia burgdorferi. This is the organism that causes Lyme disease. Burgdorferi causes Lyme disease, and the vector is the tick. Okay, so remember, recurrentis, relapsing fever, and burgdorferi for Lyme disease. You'll just have to memorize and know Borrelia burgdorferi causes Lyme disease, and the vector is arthropod vector is tick, and for relapsing fever, it's a lice. Okay, so Borrelia is diagnosed by spirochetes present in the blood. Okay, so you may see it on the peripheral blood smear. I've never seen any treponemes on the blood smear. Check for spirochetes during febrile episodes. So when the patient spikes a fever, at the height of their fever, that's the best time. And it's the same thing for malaria. When at the peak of the fever, that's the best time to collect a specimen and run a peripheral blood smear. And for staining, you want to do your typical right stain for CBC, but you follow it with 1% crystal violet. So there's an additional step to enhance the visibility of the organism on the peripheral blood smear. So the peripheral blood smear is your typical right stain, but if you're suspicious for any kind of treponema infection, then you follow it with crystal violet. Okay, 10 to 30 seconds and rinse. Serologic method is also best for Lyme disease, but not for relapsing fever. So if I want to look for Lyme disease, then I will request a serologic test. Borrelia characteristics, it's a helical rod, 3 to 10 loose coils, 3 to 25 microns in length. It can be cultured. It's microaerophilic, requires a little bit of oxygen. It's gram-negative on the gram stain, but you're not going to see it very well. And all of them are arthropod-borne, lice or ticks. Okay, remember the lice is the recurrentis, and the tick is the burgdorferi. Lice is recurrentis, and tick is for Lyme disease. Okay. Relapsing fever, recurrentis, louse-borne or lice. And the vector that you'll need to know, and I'll ask this on the quiz, so asterisk this, is Pediculus humanus. So it's the one, I mean, it's recurring, relapsing, recurring, humanus, you can say it's redundant, okay? So redundant, recurring, relapsing. Put those three together and you'll do fine with relapsing fever, all right? Relapsing fever is caused by Borrelia recurrentis, and the vector is Pediculus humanus. Recurrentis is found worldwide, poverty-stricken areas, overcrowded areas, and poor sanitation. Almost similar to the situation for the treponemas. Remember all those children in the previous section? So poverty-stricken areas, overcrowded areas, poor sanitation. Relapsing fever, the reservoir is humans only. Incubation period is 2 weeks. And after the incubation period, you get fever, myalgia, muscle aches, and headaches from 4 to 40 days, a little bit more than a month. Other clinical findings: acute septic disease, severe muscle disease, bone and joint pain, and large liver and spleen. The next one is Borrelia burgdorferi, causes Lyme disease, and the vector is the Ixodes tick. Ixodes tick, that's the name of the tick. Remember humanus, pediculus, and this one's the Ixodes tick. Lyme disease. Make sure you know this. This is one of those things, most common, one of those, I guess it's kind of like Guinness Book thing. Most common vector-borne disease in the US is Lyme disease. The most common vector-borne disease in the US is Lyme disease. Okay, so make sure you know that. The 3 stages of Lyme disease, the first one is where you see your classic typical target bullseye on the arm or at the site of infection. Okay, that's erythema migrans. Okay, the classic lesion is a target bullseye, and it's called erythema migrans. Lymphadenopathy, and the symptoms are headache. HA is headache, fever, malaise, lymphadenopathy, and it can be cultured. Okay. Stage 2 is weeks to month after the infection, and the symptoms are a little more severe or significant. You got neurologic problems, acute arthritis, meningitis, and carditis. That's stage 2, so they are pretty significant. And stage 3, you're kind of tapering down, but you're still not well. You may continue on for years. This is stage 3 of Lyme disease, and it's the chronic phase where you experience chronic arthritis. So stage 2 is the most significant one clinically because of the neurologic symptoms, arthritis, meningitis, and the carditis, and finally the stage 3 where it's more chronic with the arthritis. Diagnosing Borrelia burgdorferi. This is the Lyme disease. Culture demonstrated in tissue, but the best method to demonstrate Borrelia burgdorferi is serologic studies. The media of choice for Borrelia is modified Kellys. Make sure you know that. Modified Kellys. I asked a lot of media of choice on the homework and previous exams. So make sure you know that modified Kellys is for Borrelia, okay? And you incubate at 30 to 34 degrees, similar to 37 degrees, up to 12 weeks incubation. So you keep the culture for 12 weeks. Another technique for detecting this organism is molecular or PCR. All right, that's it for Borrelia. So make sure you know best method is serology for Borrelia, and the best media of choice is modified Kellys. Okay, the third organism and final organism in this lecture is Leptospira. Only one organism, and that's Leptospira interrogans. Okay, causes human leptospirosis. Human leptospirosis. Okay, the specimens involved for Leptospira are 3. It's either going to be blood, CSF, and urine. Leptospira specimens are blood, CSF, and urine. So, and there are time periods where blood specimen is the best, or CSF specimen is the best, or urine specimen is the best. If it's the first 10 days or first week, the specimen of choice would be blood and CSF. If it's after 7 days or 10 days, then the specimen of choice would be urine, okay? So the first 10 days is blood, first 10 days is CSF. After the second week and up to 30 days, the specimen of choice is urine. This you'll definitely be asked on a test. When is the specimen of choice? Okay, this organism, Leptospira, is flexible helical rods, tightly coiled. These are gram-negative. Again, you're not going to see these gram-negative too often because they're very faint and it stains poorly, okay, with aniline dye. This organism is an obligate aerobe, and you see it best with Darkfield microscopy, and I explained Darkfield microscopy already, or phase contrast microscopy, which is similar. And this is one of the easiest to culture. Okay, so there's 2 types of leptospirosis. 2 types of leptospirosis, and it depends on the clinical symptoms or the clinical appearance. The first one is called anicteric. Okay, so you know what icteric means. Icteric means the patient has jaundice, or if you draw their blood, it's icteric. I explained what icteric was in hematology. So something to keep in mind, if you have a patient who has the next one, which is the icteric leptospirosis, it's called Wheels disease. Icteric leptospirosis, the patient will be jaundiced, and also too, their specimen will have a lot of icterus. So as you can see, if there's a lot of icterus, what do you think will happen if they draw a CBC? You guys remember?
Repeat the question.
Okay, so if a patient has in their sample icterus, a high icterus, patient is jaundiced, so patient has a liver problem. Okay, so icterus is when, so the normal color for serum is light pale yellow, but if a patient has hepatitis or a problem with their liver, the specimen is said to be icteric. Now, an icteric specimen almost looks brown. It's greenish brown. That's icterus, or it's golden. That's a highly icteric specimen. What kind of problems would that cause in hematology?
MCHC would be high.
That's correct. The MCHC will be high because the true hemoglobin is not being measured. It's being interfered with the icterus. So what do you do with an icteric sample? How do you clear that out?
Saline replacement.
Correct. You do a saline replacement. All right. So you do a saline replacement. So if you have a patient who has leptospirosis infection and it's the Wheels disease, okay, so it's icteric leptospirosis, you might want to tell your friends in hematology, okay, I got this patient, and they won't know because they don't typically spin down their CBCs. They want to keep it rocking. But once you spin it down and you see that icteric specimen, you might let them know that you might have a problem with their CBC, and they'll see a high MCHC, and then they'll do their saline replacement. So for Wheels disease, synonyms would include mud fever, hemorrhagic jaundice, or Swineherd's disease. Okay, Swineherd's disease. Reservoirs: human, incidental dead-end host, no transmission to other animals, a wide variety of wild and domestic animals like rodents, dogs, sheep, and cattle. This is leptospirosis. Okay, so you may get on your board exam, and we did when I took my test, kids playing around your farm. Their parents own farms, and on their free time, they went to the local stream or pond and played around in the pond, and then they got sick. Okay, and the farm obviously has farm animals, and what happens is those bodies of water, like the streams and the ponds and the swamps, are contaminated with the urine from infected animals. Okay, so that's how humans contract it. So in the portal event route would be skin abrasions, mucosal sulfurs contract on the esophagus and the eyes. Primary, or the way you can contract it is on those farm animals that are infected. Occupational exposures like ranchers, vets, hunters, trappers, sewage workers, and rice sugar field workers. So anicteric, remember, an means without any, a or an, icteric means without icterus. So there's no jaundice, and it's the mild form of leptospirosis. So anicteric is not icteric and no jaundice. So if you have the anicteric leptospirosis, it's self-limiting, meaning that you'll be infected, but the disease will go away. You have high fever, headache for about a week, and it's followed by immune stage and may have aseptic meningitis. On the other hand, with Wheels disease, that's the icteric leptospirosis. It's more severe with 10% mortality. And it affects the liver, kidney, vascular dysfunction with lethal pulmonary hemorrhage. Laboratory picture is direct examination under Darkfield Microscopy. And remember, the 3 specimens are blood, CSF, and urine. Culture, you want to culture the first 10, if you culture the first 10 days, then the specimens of choice, remember, are blood and CSF. After 10 days, then you need to culture urine up to 30 days. Fatal cases, specimens would be peritoneal fluid and tissue, especially liver and kidney. Okay, so the media of choice for culturing Leptospira is Fletcher's semi-solid media. Make sure you know that. That's the media of choice is Fletcher semi-solid media. Other media include Stewart liquid or bovine serum albumin. But for Leptospira, make sure you know that it's the Fletcher's semi-solid media. And for Borrelia, remember what it was, media of choice? What was the media of choice for Borrelia?
Modified Kelly.
Modified Kelly.
Modified Kelly's. Okay, good. Okay, for culture, incubated kind of like at room temperature, that's 25 to 30 degrees in the dark, if you're going to be doing the culture, and discarded after 2 months, 8 weeks incubation. The thing about these organisms will show up after 2 weeks, but if it's negative, you keep it up to 2 months. So most positives show 6 to 14 days, a week to 2 weeks. Okay, they'll show up early. But if it's negative, you got to keep it for 8 weeks or 2 months. Darkfield microscopy will demonstrate the organism best. Make sure you know that, because what's the best method of detection? So for Leptospira, darkfield microscopy will demonstrate the organism best. Okay, and in urine or culture media. Serologically, microscopic agglutination uses antibodies and specific direct fluorescent antibody testing. Those are the serologic methods of detecting Leptospira. All right, questions and answers. So during the first week of the disease, leptospirosis, the most reliable way to detect the presence of the causative agent is by the direct A, culturing of urine, B, examination of CSF, C, culturing of blood, or D, examination of blood. What would be the answer? So this would be an early specimen. So it's either going to be blood or CSF. So in this case, it's culturing of blood. Okay, culturing of blood. After a week or after 7 days or 10 days, it would be culturing of urine. Okay, so here's the explanation. Leptospirosis species are most reliably detected during the first week of illness by the direct culturing of a blood sample. The media of choice are Fletcher semi-solid and Stewart liquid media. I'll ask you, I would expect the answer to be Fletcher semi-solid, both of which are supplemented with rabbit serum. 1 or 2 drops of the patient's blood added to 5 mL of culture medium, which is incubated in the dark at 30 degrees centigrade at room temperature for up to 6 weeks. After the first week of the disease and lasting for several months, the urine bottle becomes the urine becomes a specimen of choice for isolation of the organism. And direct microscopic examination is not reliable. Direct microscopic examination is not reliable for detection because of the low numbers of organisms normally present in body fluids. So that's why the direct microscopic observation choices were not acceptable, because of the low numbers present in the sample. So the best way to do it is by culture. Culture will be, if it's there, it's going to grow. All right. So examination due to low numbers of organisms in the specimen. Okay, next question. The etiologic agent of epidemic relapsing fever is Borrelia recurrentis, which is transmitted by Ornithodorus hermsii, Pediculus humanus, Ornithodorus erraticus, or Ornithodorus parkeri. Anybody?
B.
B. B is correct. Okay, the body louse, Pediculus humanus, actually humanus humanus is the vector for the transmission of Borrelia recurrentis. Pathogenic species not only have specific vectors, but also well-defined geographic distributions. Epidemic relapsing fevers found in Ethiopia, Sudan, and parts of South America. All right, here's another question. A positive VDRL test for syphilis was reported on a young woman known to have hepatitis. When questioned by her physician, she denied sexual contact with any partner symptomatic for a venereal disease. Which of the following would be the appropriate next step for her physician? A, identify her sexual contacts for serologic testing. B, test her serum using the fluorescent treponema antibody absorb test. Treat her with penicillin. Or D, reassure her that it was a biologic false positive caused by her liver disease. Anybody?
B.
B is correct. So the screen was positive. You need to confirm it with the confirmatory test. So infections other than syphilis can cause, infections other than syphilis can cause positive VDRL or even the RPR. The VDRL test detects an antibody that is not direct against Treponema pallidum antigens. It is a good screening test for syphilis, but it's not highly specific. Confirmation with a specific Treponema test is required. Okay, so on that note, with RPR, for example, RPR, as you know, as I mentioned, is a screening test. It's a screening test. So what happens, do you know what clinical conditions would also cause the RPR to be positive? Does anybody know? Okay, so if the patient has a connective tissue disease, or if the patient has what's called Sjogren's syndrome, or if the patient has lupus anticoagulant. So lupus, connective tissue disease, or Sjogren's syndrome, those diseases will cause you to have a positive RPR. Okay, so if you have a situation or a case study that says the patient has a connective tissue disease or has lupus anticoagulant, the connective tissue for lupus anticoagulant, then they're going to get a positive RPR. So it's not, so just because you have an RPR, those are good examples where an RPR is positive by a disease other than syphilis. Okay, so that's why when you have a positive RPR, you always want to do the confirmatory tests, the FTA, ABS, or the MHATP. All right, are there any other questions? Are there any questions? All right, no questions.